Hello. Good morning. We're going to go ahead and come together. Those in the lobby, if you can get one final sip of coffee and come on in, join us, please. Give folks a couple more seconds to come in. Lots of seats down front, you guys. There's a couple more seats down on the front too if you want to come on in. Okay, we'll go ahead and get started. Good morning, everyone. Welcome to the University of Nevada, Las Vegas. We're so happy that you could be with us this morning. My name's Ramona Denby-Brinson. I'm a professor in the School of Social Work and a senior resident scholar with the Lincy Institute. I just wanted to take a couple moments just to kind of clear out a few housekeeping things, talk about the order of the day, our agenda, our schedule. We have a wonderful day planned for you all. We're so excited. The planning committee has been eagerly awaiting this day for months now, and so we thank you sincerely for giving up your Friday and joining us. We know that time is a premium, and we appreciate your participation and your support. Hopefully when everyone came in, you should have received a folder with the PowerPoints for our keynote speakers, our agenda for the afternoon. We have several different events throughout the day, and they're going to be broken up with different breaks, and so you can kind of pick and choose how you want to become involved. Of course, we invite you to stay the entire day. We would love your company the entire day, but we will have planned breaks as we transition from different activities. So before we get started, I just wanted to give you a little bit of a backdrop on the event, kind of the vision for the event and what has inspired us, our gathering today. The UNLV Mental and Behavioral Health Coalition is a group of faculty, clinical professors, research faculty that comprise the 7 different mental health programs on campus. And that group came together about 3 years ago with the common purpose of addressing some of the workforce shortage issues in the Valley. And I won't name the 7 groups because inevitably I will leave out a group, but each group is important. They are the 7 programs that are responsible for producing our future workforce. And so these are the students that will go out and work in our hospitals, in our community health centers, they will work in our nonprofits, and they will work on behalf of some of the most vulnerable children and families in the Valley doing very important work. The coalition began to identify about 3 years ago that they had a common need, a common thread across all the programs. No matter the student's major, no matter the profession, we recognized that there was a shortage of everything. We're short on psychiatrists, psychiatric nurses, clinical social workers, addictions professionals, you name it. And so we began to do some planning on what we could do about that. And more importantly than the shortage issue, we recognize that there is an ever-increasing need to increase the overall competency and to prepare our future clinicians to face some of the challenges that our families are presenting with today. And so that's what the coalition does. They work together. They are led by Dr. Sarah Hunt, who has been the visionary behind this event. And she has put a lot of effort into keeping those 7 groups together and growing that network to extend to community groups as well. And so that's kind of what brought us together to this point. We're hoping to begin to set out, in collaboration with other stakeholders, an agenda for mental health workforce development in this state. And we're joined in this effort statewide, and this gives me a chance to acknowledge our partners across the state. Although we are headquartered down here, we actually have satellites in 3 other parts of the state. So good morning to our friends up at University of Nevada, Reno. Good morning to our friends in Carson City, and good morning to our friends in Elko. And so we're live streaming the event, recording the event. It was important for us that this effort be a statewide effort. Although UNLV has the privilege of being in a leadership role on some of these topics, we consider this to be an issue of concern to the entire state. And so we're working closely with our partners all around the state to look at workforce shortage issues and to lay out an agenda that will shore up the supply, the competency, and the adequacy of our services. And so what I wanted to do is just tell you a little bit about the order of the day. We have 2 fantastic keynote speakers that have traveled with us from Michigan. And you'll hear from our first keynote speaker, Dr. Beck, in a second. And also Dr. Huey, who has traveled from Connecticut and several layovers and some time in Detroit as well. And so we're so happy that they made the trek and they're with us this morning. But before we actually get into the program, we are so honored to have comments and a welcoming remark from Assemblyman Oscarson. He, as many of you know, he has been leading up the interim healthcare committee around mental health issues. And he has really been a trailblazer for us around this topic, bringing up the conversation, keeping the issue around mental and behavioral health in the minds and hearts of decision makers. And we're so happy that he could be with us this morning, and he wants to come forth and share a couple remarks with you. Thank you so much.
Thank you. Thank you very much. It's an honor and pleasure to be here. This is a real sensitive topic for me, especially during the interim health session. We had lots of interesting comments and discussion and passionate pleas for assistance and help in doing what needs to be done in the state to move us forward. So it's good to see so many people from so many fields, backgrounds, and perspectives come together to learn about opportunities, develop strategies to address this crucial issue. Huge thanks to University of Nevada, Las Vegas for hosting this very important event, the Lincy Institute, the UNLV Mental and Behavioral Health Coalition, Great Basin College, University of Nevada, Reno, Western Nevada College, for planning this event and bringing together such an esteemed group of state experts. Today you will hear statistics that clearly demonstrate the critical shortage of mental and behavioral health care professionals in Nevada. You will learn that while the numbers of such providers has increased slightly in recent years, and there's a couple things I want you to pay key attention to. Nevada still has fewer mental health providers per 100,000 residents than nearly every other state in the country. 16 of Nevada's 17 counties are designated by the federal government as mental health professional shortage areas, and nearly half of the state's population lives in these areas. I represent 26,000 square miles of those folks who are underrepresented in those areas. The shortage and geographic distribution of these professionals has serious consequences for individuals who need mental and behavioral health care. Nevadans in rural and urban areas alike face challenges at accessing care. Although obtaining care in rural areas and frontier areas is especially difficult, rural residents often have to travel great distances to receive mental health care, if they receive it at all. In order to improve access to care, we must increase the number of mental and behavioral health care professionals providing services in Nevada, a theme that you'll hear throughout this conference, I'm sure. This effort requires collective action on the parts of many, including everyone in the room today and those who aren't with us today, who hopefully are listening and paying attention to this important issue. We've already achieved the first step, which is bringing together key stakeholders to have open, honest, and sometimes tough conversations. Improving the workforce is not the responsibility of any single person or agency. Numerous entities have to have a role. Institutions of higher education have an opportunity to develop programs that respond to the state's workforce needs and encourage students to enroll in these important programs. Licensing boards have an opportunity to reevaluate their licensing requirements and application processes to ensure that they are doing everything possible to facilitate licensure, improve communication, and increase the number of mental and behavioral health care providers they license while maintaining quality standards and patient safety. State agencies have an opportunity to expand the knowledge and use of programs to help recruit and retain licensed mental health care providers. Policymakers at all levels can implement policies that make Nevada more attractive to providers or potential providers, reduce barriers to licensure, and expand the number of mental and behavioral health care professionals practicing in the great state of Nevada. These are just a few examples. We all have a role to play. Solutions will require reflection on existing practices, creative, out-of-the-box thinking, and potentially getting outside of our comfort zones. The 2015 legislative session, the legislature increased funding and passed a handful of bills to improve mental health workforce in Nevada. We approved $700,000 in general funding appropriations over the 2015-17 biennium to increase funding for an estimated 15 to 17 contracted psychiatric residents per year from the University of Nevada School of Medicine to provide services at Southern Nevada Adult Mental Health. The legislature also approved approximately $400,000 in general fund appropriations over the biennium to increase funding for psychiatric residents from UNSOM to provide psychiatric coverage outside the regular operating hours at Northern Nevada Adult Mental Health. This provides an opportunity for residents to gain experience and increase access to care outside of the traditional operating hours, which is when everything seems to happen, unfortunately. To improve the state's shortage of psychologists, we approved $150,000 in fiscal year 16 to fund 4 new doctoral psychology internships at SNAMS and NAMS, Carson Mental Health Center, and Lakes Crossing, and approved nearly $120,000 over the biennium to fund 17 new postgraduate psychiatric nursing slots. In addition, the legislature passed 3 bills in 2015 to increase the number of health care providers in the state. Senate Bill 68 and Assembly Bill 89 authorized certain qualified healthcare professionals to obtain a license by endorsement to practice in Nevada under certain conditions. The third bill, SB 251, ratified the Interstate Medical Licensure Compact, a voluntary licensing option that allows certain providers licensed in one participating state to apply for expedited licensing in other participating states. While these bills primarily relate to physicians, it is important that we continue taking steps similarly specified for other mental and behavioral health care providers. And those wheels are in motion, ladies and gentlemen, I want to tell you. The 2015 legislature also approved expanding medical education in Nevada, providing more than $26 million in startup costs over the biennium to support the development of the new School of Medicine here at UNLV. The medical school provides a great opportunity to grow our own healthcare providers. Students from Nevada, educated in Nevada, will hopefully stay in the state and provide much needed health care. In addition, I want to mention another new program proposed by Governor Sandoval and approved in the legislature in 2015. While this measure did not increase mental health workforce, it did increase access to care by providing funding to hire contract mental health care providers in schools. Senate Bill 515 appropriated $16.8 million over the biennium for a block grant program to Nevada's Department of Education to provide funding to school districts and charter schools to hire social workers and other licensed mental health professionals. In 2016, 161 behavioral health care provider positions were awarded based on schools' needs. However, due to the workforce shortage that we discussed previously, recruiting providers was quite challenging, but 153 providers were ultimately contracted or hired. I would call this program a success. We increased access to care for many youth who need it, but it also presents an opportunity. The Legislative Committee on Healthcare, which I chair, heard much testimony throughout the interim regarding schools' challenges in recruiting qualified mental health professionals, as well as the difficulty professionals licensed in other states face when applying for licensure in Nevada. We have an opportunity to learn from experiences like this and improve every step of the process so that we can successfully increase access to mental and behavioral health care. The Legislative Committee on Healthcare continues to work to address the mental health care workforces through 2015-16 interim, and in response to testimony from a variety of stakeholders, approved 2 bill draft requests aimed at mental and behavioral health care. The first BDR proposes enacting the Psychology Interjurisdictional Compact, which allows a psychologist licensed in a state that is a member of the compact to provide services to patients in other compact member states. The second BDR proposes moving the 4 behavioral health licensing boards under the oversight of the State Board of Health and Division of Public and Behavioral Health within the Department of Health and Human Services. These include the Board of Psychological Examiners, the Board of Examiners for MFTs, Clinical and Professional Counselors, the Board of Examiners for Social Workers, and the Board of Examiners for Alcohol, Drug, and Gambling Counselors. The BDR aims to eliminate unnecessary barriers to entry into the field of behavioral health, streamline licensure application processes, and improve efficiency across the behavioral health care licensing boards. It capitalizes on existing infrastructure within the Bureau of Healthcare Quality Care and Compliance to standardize and streamline applications, processes for similar professions, and reduce administrative costs. It ensures that experts in each respective field continue to develop regulations, standards of practice, and licensure requirements for their own behavioral health care discipline. It provides for much needed and current non-existing oversight of the boards whose decisions will be reviewed and approved by the State Board of Health. Most important, though, the BDR is one step the committee can take to begin addressing the myriad of issues we heard throughout the interim and help reduce unnecessary barriers to entry for people who want to work as psychologists, social workers, counselors, and other behavioral health providers in Nevada. Last page, so you can all... As you may be aware, numerous opportunities exist throughout the legislative session to provide input on proposed legislation. If you have ideas or concerns, please come and participate so that we can continue moving the needle on this very important issue. Let us all continue to look for innovative solutions to ensure that all Nevadans have access to high-quality mental and behavioral health care, which is all our goals. Thank you again for being here to participate in the discussion today. Please know that my door is always open. My phone is off and on, and I encourage you to share your thoughts on improving healthcare in our great state. God bless the state of Nevada. Thank you very much. Thank you. Thank you very much.
Thank you, Assemblyman Oscarson, for laying the ground for us and providing an overview of kind of where we've been in our progress with respect to building our mental health workforce, and also noting that much work remains, and that's the charge for us and for this group that's assembled today. So we're going to shift gears a little bit, just a little bit more about the order of the day. Our first keynote speaker will start and speak for about 45 minutes or so. She will build in time towards the end of her talk to take questions from the audience. We also have people that are viewing the forum on satellite, different sites, and so questions will be coming in from people in other parts of the state as well. We're going to try to consolidate those questions throughout the day. Many of you, when you came in, you probably were giving little note cards to index cards, and so if you want to take note of some of the questions that you have, because we're on a tight time schedule, we're going to apologize in advance if we cannot get to everyone's questions, but what we're trying to do is collect those note cards throughout the morning and streamline the questions and pose those questions to our keynote speakers as well as the panelists that will come up next. And so just by way of introduction, Dr. Angela Beck is from the University of Michigan, where she is the director of the Behavioral Health Workforce Research Center. They are doing some incredibly exciting work. Her center was recently funded to look at mental and behavioral health workforce issues quite broadly. Actually, they're looking at 12 issues, and she'll talk a little bit about those from across the United States. What's unique about her perspective, even though her talk definitely informs the work that we do here in Nevada, she has the benefit of looking at this issue from a national perspective. And so she's going to share with us some of the work that they've been doing and some of the ideas and some of the innovative things that are taking place across the country. So please welcome Dr. Angela Beck.
Good morning. Thank you to Sarah and to Ramona for inviting me to speak today. As Ramona said, I'm Angela Beck. I'm director of the Behavioral Health Workforce Research Center at the University of Michigan School of Public Health, where I'm also faculty in the Department of Health Behavior and Health Education. Today I'm going to spend some time telling you a little bit about our Workforce Research Center and the resources that we might be able to offer you. I'm also going to tell you a little bit about what we know about Nevada's behavioral health workforce in terms of size and composition. And then I'll spend some time talking about 3 strategies or opportunities to try to strengthen behavioral health workforce capacity. So a little bit about our center. As Ramona mentioned, we're a newly funded center. We were established about a year ago in September 2015. We are part of the Health Resources and Services Administration's Health Workforce Research Network. So there are 7 centers. We are the most recently funded center. We're unique from the others in a couple of ways. First, we're the only one that is solely focused on behavioral health. So some of the other research centers do cross over into behavioral health a little bit, but we are the only ones that are solely working on behavioral health workforce research. We're also jointly funded by HRSA and SAMHSA in our efforts. And we work through a consortium model, and I'll introduce you a little bit to our partner consortium in just a few minutes. We have an interdisciplinary core research team at our center. As we were developing the grant proposal for this center, we realized very quickly that we really didn't have anyone at the University of Michigan who was an expert in behavioral health workforce research. So we developed an interdisciplinary research team. We have investigators from the School of Social Work. We have investigators from our Department of Health Management and Policy who are experts in things like integrated care for behavioral health, service delivery. And my own personal background is actually in public health workforce research. So behavioral health is a little bit newer to me, but we're trying to apply the methodologies and the strategies that we've used to tackle some of the public health workforce challenges to behavioral health. This is our partner consortium. As you can see, we have representation of organizations on the mental health side, on the addiction side. We have our public health partners involved. I would say one of our key partners in this consortium is the National Council for Behavioral Health, which really serves as a subcontractor on some of our projects. The consortium collectively is in place to guide our research. So they tell us what research questions are important to the field. We don't want this to be an academic institution driven project where researchers are deciding what's important for folks in the field. We need the community to tell us what's important, and we provide the research infrastructure to get those projects done. We have 2 key consultants to this grant, Ron Manderscheid, who's been in the behavioral health field for a long, long time, a wonderful partner to our center, and Peter Bierhaus, who is a well-known health economist and has specific expertise in health workforce research. So our center was established really to help try to address some of the issues in the behavioral health workforce. You may be familiar with an Annapolis Coalition report that really framed out how behavioral health has a workforce crisis. And in their report, they listed some elements of that, including increased demand for behavioral health services. So we know that demand is going up, in part due to things like Medicaid expansion associated with healthcare reform, with Mental Health Parity Act. Those are just a few of the reasons that demand is going up. But overall, we have too few workers nationally to meet this demand. And it's not just a numbers situation. We also have a poorly distributed workforce. So the people that we do have tend to be clustered in certain geographic areas or communities, leaving other communities, often rural communities, with little to no service access, no providers. There's also a need to better train the workforce that we have in place, particularly in things like integrated care and treatment of co-occurring disorders. And overall, the field of behavioral health lacks systematic data collection for workforce. So we know that these challenges exist. We know that we have a way to go. We're limited by our capacity to move things forward based on the level of data that we have to provide evidence-based solutions. So these are the main focus areas of our center. We have 3 focus areas that were defined by HRSA and SAMHSA. The first involves a development of a minimum data set, and I'll talk about the minimum data set in more detail in a minute here, but briefly, a minimum data set is a way to develop a common set of data elements to improve data collection and data quality. We also have studies around characteristics and practice settings for the behavioral health workforce, and this focus area is really a mixed collection of projects. So we're looking at things like workforce diversity. We're interested in studies on team-based and integrated care, which I'll also highlight today. We're interested in telehealth, so other mechanisms for delivering behavioral health services. Our third focus area is around scopes of practice. And I'll talk about that in more detail in a minute too, but we're looking both at legal scopes of practice that we find in state statutes and also professional scopes of practice that are set by the field. We are contracted to do 4 projects in each of these focus areas per year. So we're doing 12 research projects per year. We're funded for a 3-year project period. So we have quite a bit going on, and I'm happy to be able to share some results from a few of these projects with you today. So the first thing that we had to do with our partner coalition is decide, what do we mean when we talk about behavioral health workforce? If you look at the literature, if you look at reports from SAMHSA, if you look at HRSA, if you look at professional organizations, you will find a different definition of behavioral health workforce through all of those organizations and resources. So we had to decide as a research center for our 3 years, and hopefully longer than that, who do we mean when we're talking about behavioral health? Well, as everyone in this room knows, behavioral health workforce is broad, right? It's a diverse group of people in terms of occupation, in terms of educational background and training. When you look at the research that's primarily available on the behavioral health workforce, you will find that it mostly centers on what you might consider the core licensed professionals. So psychiatrists, psychologists, marriage and family therapists, licensed professional counselors, social workers, psychiatric nurses, all incredibly important, all absolutely a part of what we would consider our behavioral health workforce definition. But we don't want to stop there. We want to go more broadly than that. We need information on peer support, incredibly important part of the workforce. We need information on what we would consider sort of mid-tier workers. So perhaps they're not licensed, perhaps they're certified. We don't have enough data on them. We don't have enough information on how they're providing services. So our consortium decided that for the purposes of our center, the behavioral health workforce is anyone involved in prevention or treatment of mental health or substance use disorders. So this is a functional definition. We're not looking so much at occupations, and you're only in if you're a certain occupation. If you're providing services, we're interested in you. We want to know more about you. We want to include you in our supply and demand models. It's a big charge. There's not a lot of information about this whole group. So I want to shift gears a little bit and tell you what we know about Nevada's behavioral health workforce. Now, I just spent a lot of time telling you that it's important to think of the workforce broadly, right? Now I'm going to show you what data we have available to us. This is data from the Bureau of Labor Statistics, which is one source of behavioral health workforce data, not the only, but it is a key source. And you can see here that we're primarily limited to 8 occupations that have standard occupational classifications in the federal system that they use for data collection. So you can see here we have psychiatrist, psychologist, marriage and family therapist. Mental health counselor has its own occupational classification from substance abuse and behavioral disorder counselor. Mental health and substance abuse social worker has a combined occupational classification, psychiatric aide, and psychiatric technician. So you can see in Nevada, you have a pretty small psychiatrist workforce here. The bulk of the workforce is in counselors, in marriage and family therapists, and in psychiatric aides. So this is showing 3,200 workers in the state of Nevada. We know you have more, right? There's a big group missing here. There's no psychiatric nurses on this list. They don't have their own standard occupational classification that we can pull data from. So we're already seeing limits in terms of the data quality that we have or the data resources available to us when we're trying to do workforce planning. So in this slide, we've taken this information on the pie chart and we've pushed it into a bar graph. And so this first bar is Nevada. The second bar is Region 9. Nevada is part of Health and Human Services Region 9. So these are your regional colleagues here. And then the third column is the United States. And so in this, we're not so much concerned about the numbers, but looking at the composition of the workforce across these three bars, we would look to see is there consistency? Does Nevada look different in terms of the colored blocks than in Region 9 or in the United States? And you can see, overall, it looks fairly similar, although I would point out at the top and at the bottom of the bar, psychiatric technicians and psychiatrists, smaller than the rest, right? Marriage and family therapists, certainly a little bit bigger than the United States. Psychiatric aides, larger block there in terms of composition compared to Region 9 in the United States. Now this isn't telling us anything about shortage. This isn't comparing numbers. This is just looking at the composition of the workforce that you have relative to the composition of the workforce in the region and across the country. So let's look a little bit at supply. Now we're looking at numbers. So the 8 providers that we have information for through the Bureau of Labor Statistics are listed in the first column. And then we have numbers for the United States, numbers for Region 9, and then the last 3 columns are numbers for Nevada. So you can see, looking at psychiatrists, there are about 24,000 psychiatrists in the US according to BLS data. Almost 4,000 of those are in Region 9. 40 of them are listed in Nevada. The next column over, the LQ, that is a location quotient, and that's a ratio that BLS uses to try to compare the concentration of these certain occupations across the country. So if you have a location quotient greater than 1, that means you have a higher share of that occupation employed in your state compared to the national average. If you have a location quotient less than 1, that occupation is less prevalent in your area than in the rest of the country. So if you look at the location quotients across these 8 professions, you're above 1 in marriage and family therapist. That looks pretty good. Really low in the others, right? And if you look at that location quotient and do a state ranking based on it, psychiatric technician, last compared to the rest of the states in DC, and psychiatrists, second to last. The rest are kind of in the mid to low 40s. So this would signal to me that there's a potential capacity issue, okay? Understanding the limitations, that there are groups not represented on this slide, perhaps they're better, but we want to start thinking about, do we have the supply? This isn't necessarily signaling shortage yet though, right? To know if this is not enough, we'd have to know what you need. So if I were seeing studies of prevalence estimates that showed that there were lower prevalence of mental illness or addiction in Nevada compared to the national average, maybe this is okay. Maybe that would be all right. That's not the case, right? We know that. Studies show that Nevada has prevalence rates of mental illness at or above national averages. There have been statewide efforts in terms of needs assessments that have looked at challenges with mental health service utilization, things like waiting periods, not enough providers to meet demand. And as was mentioned previously, HRSA has designated mental health professional shortage areas across the state. So I think we're safe to say that there is a shortage problem here. What I would like to be able to say to you today is, here's what you have, here's what you need, and here are some strategies for getting there. The lack of data limits that. We are limited in trying to determine what the ideal workforce size is, what types of workers you need, and how they should work together to deliver services. So I want to talk through a few strategies for strengthening workforce capacity, and it's not that these are necessarily, they're certainly not the only strategies. You could think of things like enhancing your workforce pipeline, investing in your behavioral health professions schools to get more people trained, finding ways to encourage folks at a younger age to be interested in these professions. You could think about things like recruitment and retention. How can we incentivize people to work in Nevada in these professions? How can we incentivize people to work in those communities that lack providers and retain them there? So those are certainly important strategies. I'm covering these three because our center has done some work around these areas. So I'll highlight these for you now. We'll start with data. Have I mentioned we have a data collection problem? Okay, yeah. I'm going to stick with that for just a little bit longer. So this, just to further reinforce this point, this is a table that came from a Congressional Research Service document. And what they try to do is lay out workforce estimates by mental health provider type. And so in one column, they have data that came from an Institute of Medicine report that is largely based on the Bureau of Labor Statistics data that I mentioned previously. And then they have a couple other columns that come from other sources. So things like data from licensing boards, or membership lists from professional organizations, or universities collecting data, consulting firms collecting data. If we take an example here, let's maybe look at the third down, so clinical social worker. You have one report listing 115,000 clinical social workers. You have another report listing 245,000 clinical social workers. So when you're thinking of planning, this is a problem. This is a problem. All of these data sources are being collected, the data are being collected in different ways using different methodologies. They're all correct in their own way. It's not that one is necessarily more correct than the other. They mean different things. So as a workforce researcher, you have to decide what's your definition of the workforce you're trying to make inferences about, and what numbers are you going to use when you do your workforce modeling. So how's our center trying to help with this? So one of our tasks is to develop a minimum data set for the behavioral health workforce. Has anyone heard of the term minimum data set? Is this a familiar term? Okay, yeah, some folks in the room have done this. This is not a new concept. A minimum data set is basically a uniform set of data elements that we would use in data collection instruments to try to improve the consistency and the comparability of behavioral health workforce data across these different types of surveys and studies, so that we're cutting down on this range. So we're collecting data in the same way, and the numbers mean the same thing. If you Google HRSA MDS, you'll come up with this website over here, and you will see that there are existing MDSs for health professions, and even for a couple behavioral health professions. What our charge is to develop a minimum data set that broadly includes all of those types of occupations that I mentioned earlier. It's a challenge, right? This is a group with a lot of varying characteristics. So our challenge is to determine what is it that we need to know in common about all of them to do better informed workforce planning. What does an MDS look like? Well, this is a little kind of snapshot of it. It kind of looks like a survey instrument. It's not actually a survey instrument in itself, but it's more of a resource for people who are doing surveys or doing some type of data collection to go to this and see how to ask the question, see what types of response choices to use, so that we're collecting data in a similar way. So we've come up with many data elements, and we've kind of grouped them into 5 main topical areas, and that includes demographics, education and training, licensure and certification. We want to know what their occupation is and their area of practice, and then information about practice characteristics and settings. And the idea being, if we can collectively get this information on as much of the workforce as we can do a better job with workforce supply and demand information. The other piece of this MDS project, our center looked at the existing behavioral health workforce data sources across the country that we could find. We identified almost 150 different types of data sources that included some information about the behavioral health workforce, and then we rated them on a series of metrics here and also compared them to those minimum data set data elements to see if we could come up with a system where, well, maybe these data are being collected in different sources, and if we piece them together, maybe it's not perfect, but maybe it can get us a better idea of what we're looking at broadly on a national level. So what this is just showing you is, we have our data sources that we looked at here, and these are national level data sources, so they're collecting data nationwide on workers. We were interested in, do they cover enumeration, so are they telling us what the size is of the workforce? And here are our minimum data set elements here. Do they cover demographics, education, licensure, and so on? Where do we have data gaps, and what do we have data for? We then looked at the validity of the data, so the extent to which it's accurately providing information about the behavioral health workforce. We looked at reliability, so is it showing the same type of information over time? Are the data reliable? We looked at frequency. How often are these data collected? Is it reasonable to use these data sources as a way to do continual monitoring of the behavioral health workforce? And we also looked at accessibility. Are they available publicly? Or is it difficult to abstract these data? Overall, we found that there was not a good way to piece together. There is certainly no single data source, but even looking collectively at the national data sources, we have data gaps. So we either need to think about how we're collecting data currently, or we need to do additional primary data collection to fill in these data gaps. You can see here validity. We rated these on good, fair, poor, unknown, and granted these are our own judgments about these metrics, but we struggle with valid data. And when you have policymakers asking you how many workers you need and you don't have valid data to back up your recommendations, that's a challenge. That's a challenge. We also looked at state-based data sources. So we were interested, we didn't analyze these for content or along those same metrics, but we were interested in, are there state initiatives to try to collect these data in-house, so to speak. And we found that overall, most states are trying to do something. Maybe it's on a segment of the workforce. It's probably not on the whole thing. And it's certainly not collecting all of those MDS data elements. But are there organizations or university partners that are trying to do this? A couple, no. We found a variety from 0 data sources to 4 data sources. We found 2 in Nevada. And these are what we found. So we found a data source at the University of Nevada, Reno. We found a data source at the Nevada Department of Employment Training and Rehabilitation Research and Analysis Bureau. If you know of others, please let us know. We really are interested in developing some sort of toolkit or resource place where folks can go to identify the partners that are collecting information on the behavioral health workforce. So in summary, in terms of addressing workforce data limitations, we think that the use of a minimum data set can help with data standardization and quality. We don't think that we have a data source or a combination of data sources that can provide all of the information we need for behavioral health workforce planning right now. I have not heard that there will be funding or support for a national source for data collection in the near future. In other words, HRSA and SAMHSA are not funding our center to do primary data collection for the entire country for the whole behavioral health workforce. I wish they would, but I don't see that in the near future. So look to your university partners, look to us, look to UNLV, look to your university partners to help provide technical support if needed to try to move this forward. I also wanted to mention that licensing boards in particular have a big role in data collection. I featured BLS data today, but I could have looked at licensing data and probably would have seen a little bit different picture in terms of numbers. I think the story overall would have been the same, that there's a shortage, but you would see a little bit different information from licensing data. It would be wonderful to encourage licensing boards to adopt some of these minimum data elements, minimum data set elements. They would need resources to do that, right? They're usually not funded or resourced either in terms of personnel or in terms of technical expertise to do this kind of data collection for us. Would be wonderful if we could work toward that. So I'm going to switch gears a little bit and talk about best practices related to team-based care. When I talk about team-based care, this is a model of integrated care. So I'm talking about integration of services between behavioral health and primary care, but also integration of services, mental health services and substance use disorder services. We know from the literature that integrated care has been shown to be a good thing in the organizations that have adopted it. So we've seen more positive patient outcomes. We've seen increased access to services. We've seen positive outcomes on the organizational side too. Better employee productivity, job satisfaction increase, decreased costs overall. So I think that in general, folks are on the same page that integrated care is a good thing, but it's not easy to adopt. There are challenges. Our center did a series of case studies this year with folks who have adopted a team-based care model. And these models look different across the country. Each organization kind of implements these a little bit differently. But we were interested really in the workforce angle of this. So you're doing team-based care. What does your workforce look like? How did you decide who needs to be on the team? How did you train them and get buy-in? What are some of the barriers and best practices that you ran into when trying to develop and deliver this team-based care model? So I'm going to give you some information from our case study findings, sort of the top 5 barriers to implementation in no particular order, but these were themes that came out frequently in our key informant interviews. So the first one being, clinicians may initially be resistant to this transition, so they often lack understanding about how integrated care works, what the workflow would look like, what is my role. Number 2 is folks were saying, we don't have enough providers as it is. You need people to have a team, right? We don't have enough people. So trying to think through how to address some of the clinician shortages to even implement a model like this can be challenging. Number 3, there are difficulties in record sharing, particularly for patients with substance use disorders. So we're hearing providers say, I would love to do integrated care. I don't have access to the medical information I need about my own patient to be able to do that. That's a problem. That's a legal barrier. That's a problem. The boxes in the corner here are some quotes that we heard along the way in our study. So this one is saying that our site is constantly recruiting, trying to get the right person that will work in this integrated care setting, and we're constantly dealing with folks who just kind of don't get it. We're not sure how to get everybody on the same page. Barrier number 4, I mentioned clinicians are unsure about the workflow. Sometimes administrators are too. Unsure how to implement this effectively. There are physical space constraints often that make co-location of providers difficult, so working through some of those administrative challenges is important too. And then finally, many noted a lack of financial support for integration. So we think this is a good idea, we want to do it, we don't know how to bill for it. There's no way to kind of get reimbursement for all of this work that we have to put into making this integrated care model work. Also some other issues related to billing restrictions, like can't bill for physical and mental health services on the same day. So even if I co-locate my providers and my patient is here, I can't bill in that way. So again, these are some administrative and sometimes legal barriers that folks are running into in trying to develop team-based care models. But they're doing it. So we also asked them how. We also asked them about their best practices. And here were a couple of things that they noted. It's important to get buy-in from leadership and providers at the beginning. Trying to implement the model and bring people on board later, not so successful. Get people involved from the beginning so everyone's kind of working through what that workflow might look like together. Help providers understand what their collaborative roles are and the importance of this team structure. So you might have resistance from some providers who used to provide or are used to providing certain services, turning those services over to someone else. That's a challenge, but getting everyone on the same page and reassuring folks that yes, so-and-so is trained to do that. We will not suffer in quality if we turn this over. That takes some time. That takes some trust to build. Be clear about the benefits. So we are hearing from folks that once they get the integrated care model in place, employees tend to like it. That when collaboration occurs, caseloads often feel easier, patients have better access to the services they need, and they respond better to treatment. So benefits on both the provider and the patient side. And finally, we heard over and over that in-house training is key, that providers are not learning integrated care models for the most part in their degree programs. So they're coming in, it's understandable that they don't understand, that they don't know what this model means or what their role would be. So to be sure to have resources in place and understand that you're going to have to train providers in-house on how to do these models. So with that, I'm going to switch gears a little bit more and talk about behavioral health scopes of practice and the impact on workforce capacity. So when I talk about scopes of practice, I'm talking about the legal scopes of practice that would be found in state statutes, for example, that would delineate the authority that each type of occupation has to perform certain tasks. Not everybody has a legal scope of practice, though. So we also looked at professional scopes of practice that would be set by perhaps a certification body or professional organization, someone in the field that's describing what folks are trained to do and should be doing. In general, we know that there's some misalignment with scopes of practice among behavioral health professionals in terms of what they're trained or authorized to do and what they're actually doing. And it's driven by a couple of things. So sometimes it's legal restrictions that are imposed by state statute. Sometimes it's billing restrictions. My provider is trained to do this, but I can't get reimbursed if that provider does it. And also, this is a sensitive area, as I'm sure folks in the room know. Professions are very protective of their scope of practice. They tend to want to see their own scope of practice increased often, but they don't want other people's scopes of practice increased and infringing on what they can do, right? So it's a sensitive issue. It's a challenging issue, but I think it is an area that can be addressed to help with workforce capacity. So what our center did was we took a look at scopes of practice across the country, and our key research questions were for which professions are state scopes of practice accessible and available? What elements do they contain? And what is the variability of scope of practice across the different professions and the different states? So we looked at every state's statutes, administrative codes, we looked at certification programs, we looked at job classification materials to find language for 10 behavioral health professions, and they're listed here, so you can see certainly some of those core licensed professionals are included, but we also included some other folks that perhaps are not licensed, and that's where the professional scopes of practice come into play. We took that information and we extracted data from all of those documents and coded them into different variables and completed 3 sub-analyses. So the first is a macro state analysis. And at this, we're really looking at descriptive information. So what are the names of the certifying or licensing bodies? How often are these statutes updated? When were they last published? And what are the professional definitions for each of these occupations across the states? Do they vary? We were also interested in licensure variables. So we're looking at elements of the scope of practice that define things like how much supervised work experience is required for licensure or licensure renewal. What are the examination requirements? What are the continuing education requirements? And is reciprocity permitted? I heard an ooh. We also looked at available services. So we identified some services that are common among behavioral health service delivery. And we took a look to see if the scope of practice specifically indicates whether or not that professional can engage in that type of service delivery. So for 9 of the 10 professions, we were looking for presence or absence of this content across the scopes of practice. For social workers, we used that as sort of a pilot test and went a little deeper. So we went past presence or absence and went to, if it's there, how does the content vary across the country? We're still working on this analysis. So I want to bring this down to Nevada for just a second. I looked at the data that we collected for Nevada, and we found both some best practices and scopes of practice and some opportunities that we think for improvement. Nevada permits marriage and family therapists, licensed professional counselors, psychiatric nurses, and social workers to diagnose behavioral health disorders. That's not true of all states, so we think this is a good thing. Nevada allows licensed professional counselors and marriage and family therapists to be trained and supervised by other licensed professionals. Some states, if you're a marriage and family therapist, you can only be supervised by a marriage and family therapist. And sometimes that creates a barrier to getting the required supervision completed. Nevada has a licensed position for addiction counselors. We did not see that in all states. And interestingly, Nevada has included telehealth authorization in almost all of the individual professional scopes of practice. So what we were seeing with telehealth is nationally, it's either not mentioned, it's in one statute that is supposed to be applicable to all behavioral health professions, or it's specifically included in every professional state scope of practice. That's what Nevada does. We think that's a good thing. Opportunities for improvement. I mentioned we looked at this for 10 behavioral health occupations. We could not find 2 of them specific to Nevada, so we did not find information for prevention specialists or psychiatric rehabilitation specialists. We found that many states have a certification board for behavioral health. We did not see that for Nevada. We also found that social workers and addiction counselors are required to have advanced degrees before entering practice, but we did not find specifications about the core curricula or the academic credit hours that are required in order to qualify for licensure for those professionals. So maybe some more specificity needed in the state scopes of practice for those professions. And I think one thing that stood out to us loud and clear was this issue of reciprocity. So few routes for out-of-state professionals to get a license through reciprocity, and I think this is a challenge. It can inhibit quality workers from moving into the state. It can exacerbate potential problems with workforce shortage. So this one definitely stuck out to us as an opportunity for improvement. These are the services that we looked at specifically in the scopes of practice. So we looked at assessment, diagnosis, psychotherapy, crisis intervention, custody determination, and telehealth. And again, we were looking for presence or absence of these elements within the scopes of practice for the 8 occupations that we found for Nevada. Pretty good coverage overall. Custody determination wasn't mentioned in any of the scopes of practice. It likely wouldn't be relevant for all of them. But overall, compared to other states in the country, I would say probably more comprehensive in some ways in terms of presence or absence than some other states. But we'll look in a minute about level of detail for some of these. So these are the supervision hour requirements that we found in the scopes of practice. The blue bars are Nevada requirements. The yellow bars are the national average. So you can see along the bottom the 8 different, well, actually all of the different occupations that we looked at. We did not have that information over here for prevention specialists, psych rehab specialist, or psychiatric aid. So those are just the national averages for your information. But you can see that there are some differences. Not substantial, I would say, above in some professions and lower in others. So for psychologists, for example, the Nevada requirement is 1,750 hours. The national average is 2,262. But then we look at average supervision time required in months, and we have the same occupations across the bottom here. Again, the Nevada requirement, blue bar, US average, the yellow bar. Interestingly, psychiatrists, much higher than the national average. So could this be a recruitment barrier? I don't know, maybe. There are certainly a lower proportion of psychiatrists in Nevada compared to the national average. I don't know whether this is a recruitment issue or not, but perhaps something to consider. These right here, again, we don't have Nevada data, so they're the national average for your information. So in summary, just one more time, we need better data to address workforce size and composition problems. It may be worth addressing barriers to adopting best practices, particularly related to team-based care that might involve looking at payment mechanisms or ensuring that you have the appropriate training resources available if you want to implement those models. And then I do think refining legal scopes of practice and looking at things like lack of license reciprocity and how a change in that might improve workforce capacity in your state. In terms of our center, we are a resource for you. We are funded to be a resource for you, so please do reach out to us. We are doing national level studies. We'll continue to focus our work along several themes, so we're very interested clearly in vulnerable and underserved population and how service delivery is happening. Over the next year, we'll be focusing some projects specifically on the workforce providing services in correctional facilities. We're interested in workforce factors that impact service delivery. So team-based care was one I highlighted today. We'll be doing some work on telehealth in the upcoming year. And we'll continue to do some discipline-specific studies. So certainly those core licensed professionals, but we want to move past that as well. If you have thoughts, if you have suggestions on research topics, on things that would be helpful to you, on things we should be doing, please don't hesitate to reach out to us. Our website is here. We'll be launching our new website in the next couple of weeks. We'll have our policy briefs and our reports of findings available soon. We're on social media. Feel free to email us. We really do welcome your suggestions, your collaboration, and your involvement. With that, I'm happy to take any questions you might have.
While you're filling questions from this group, I'm going to go and check to see if we have questions that come in from the satellite site.
David Robeck from Bridge Counseling Associates here in Las Vegas. Oh, great. Thank you. I thought I had a big mouth, but this is better. I'm going to get one for work, I think. My question is, in the data that you collected for the mental health professionals here, you also had a different category for addiction professionals. And in the agency I run, I get licenses for both. We do dual diagnosis and co-occurring treatment. So I was just kind of curious how that affects the total when you're analyzing, for instance, Nevada even, if we're actually much lower than what you have presented.
Yeah, that's interesting. So for the data source that I cited with BLS, the way they collect their data, it's essentially self-report. So people would have to choose one category or another. So hopefully they're not being double counted. But certainly, do I know that for sure? I don't. We would need more detail on the state level to know that for sure. I wish I had known that this would be an issue before I got here because I could have looked into that a little more specifically. I can't give you that information at this point. It is something we can certainly look into because we do have information on that through the work that we've done related to scope of practice. So it's something I would have to go back and kind of do a little additional analysis on. But I'm interested in hearing the panel discussion today because I think it will be informative for me too.
John Beckham, University of Nevada, Reno School of Medicine. On your scopes of practice research, is there any attempt in the work that you're doing to link that to quality of care or outcomes in health? Because I think one of the barriers in Nevada is anytime this is discussed in a legislative or a regulatory body, you hear all of this anecdotal information on how detrimental it will be if we change scope of practice in any area.
Yeah, that is certainly what we would hope to do down the road. You're right, there is a lack of evidence base to support recommendations right now. You can kind of see from the scopes of practice where there might be misalignment in terms of what people are trained to do versus what people are permitted to do, but we don't have studies, certainly, that show if these people do it, it's better outcomes than if these people do it. Maybe a little bit through some very small studies in very specific disciplines, but we lack that overall for the behavioral health workforce. I would love for our center to move in that direction. I think we're limited somewhat. I mentioned we have 12 projects to do per year on a 12-month timeline. It means that we can get at breadth of behavioral health workforce challenges, but we lack the time and resources to get into depth, and I think that's a depth project that I would love to see us or anyone do, because I really think that is the next step that's needed.
Well, if you need a case study, come back to Nevada.
Okay, fantastic.
Hi, as a licensed LPC in 3 different states, just wondering in your research, when you were looking at reciprocity, did you or were you able to analyze barriers? And what I mean is that in other states, an application is submitted, it's processed, you get your license. But in Nevada, the board meets once a month, you have to submit an application, you have to be interviewed. So that prolongs it, it causes a barrier, especially when you're trying to move in the state. So in your research or analysis, are you able to see even barriers in the application?
I think we will be able to see that, particularly when we finish our more in-depth study on the social work group. I think we will be able to get at some of those barriers. In general, I can tell you anecdotally what we're seeing is sort of a mix of administrative barriers, like the ones you're mentioning, long wait times to get license applications approved, barriers in terms of education requirements or supervision requirements, that one state doesn't match another state, and sort of an inability to modify the requirements to sort of facilitate this reciprocity. And I don't know to what extent the professional groups are involved in trying to either facilitate or limit reciprocity. That isn't clear to me nationwide, but anytime you're looking at scopes of practice, there are professional groups involved with trying to help decide which way this goes. So that would be something I'd be interested in looking at too. So I hope to have more data on that as we move forward, but it's a really interesting point to not just point out that there is a problem, but why is there a problem and how can we start to address some of those barriers.
Tracy Green, UNLV School of Medicine, back here.
Hi.
I had really a 2-part question. One was, when you're looking at workforce, do you look at Medicaid and enrollment? Because one of the barriers that we see is that we can bring workforce in, but they either can't be reimbursed for a service or they're not being allowed to be enrolled in managed care. Yeah. And the second question I had was, are you looking at all at behavioral health centers of excellence and whether that certification or that qualification either keeps people more in states or brings in more workforce?
That's a really interesting point. To the second question, we have not. And that's a good suggestion for us to start considering that as we move forward in our projects. For Medicaid enrollment, we're touching on that a little bit, but mostly in terms of scopes of practice, and looking specifically at the billing restrictions that limit scopes of practice or service delivery. So we're doing a little bit of work around that this year, and we'll have some analysis available for that shortly. But your point is well taken, and it would be worthy of a more in-depth study on its own to kind of look at what are the factors specific to Medicaid enrollees that are a barrier to either service delivery or access.
Adele Solomon, Health District.
Sure.
Hi, I just wanted to know what you're looking at when you're talking about moving into research in the jails.
Sure, and that is a project that we're still defining what the study design would be, but in general we're interested in what types of workers are providing services in correctional facilities and what happens when folks move out of that facility and where is a transition of care happening or not happening, and what are some barriers that we can address long term to try to improve care. We are working very closely with county mental health and developmental disability directors, and by and large, this is the #1 priority that they keep talking to us about. We need more information on how we can deliver better services in correctional facilities. Jails and prisons are the biggest psychiatric institutions, right? So it's a population certainly in need. We have some flexibility to bring partners on board early this year to help decide what that research plan might look like. But in general, it's going to start as an assessment of the profile of the workforce that's providing services so that we can start to lay the baseline on supply, and then we'll get to the demand piece of it.
I want to give you a couple questions that are coming in from our partners up north. This question is from Dr. Sean Dodge with the Division of Public and Behavioral Health. He wants to know, Dr. Beck, are you aware of any states that have successfully increased their behavioral health workforce recently? Are there model programs that Nevada can take a look at?
It's a great question. I don't have states in mind specifically for you. What I can tell you is with the varying projects that we're doing, the next step with them once we get the analysis will be to try to look across them to see if we're finding patterns that certain states are performing higher in certain ways or indicating more positive research results than others. I don't have an answer right now as to states that I have seen right off the bat who have either invested in behavioral health in a certain way and have seen a positive growth, or have implemented workforce pipeline programs, for example. But I know those programs are out there. I think the challenge is seeing the outcomes of them. I haven't seen anything that definitively shows outcomes of the things that are being implemented nationwide.
Okay.
Good morning, Dr. Beck. Janice Wiggins, State of Nevada, in the Office for Consumer Health Assistance. With regards to the issue that you presented about physicians not being able to, or providers not being able to bill for physical and mental health in the same day, are you aware of any initiatives to address that barrier?
I hear it talked about a lot. I'm not aware of specific changes in being made by insurance companies to facilitate that yet. I know it's something that has been discussed nationally a lot, though. As there is more of a movement toward integrated care, it's going to be an issue that has to be addressed, but I have not heard anything specific that would change those types of barriers yet.
Okay, we're probably going to need to wrap up. So you guys, please join me in thanking Dr. Beck for her presentation. Thank you so much, Dr. Beck, for that wonderful presentation. We're going to take a little bit of a break, but we're going to ask if we can shorten the break because we need to get back on schedule. So we have refreshments out in the foyer. I can't see the clock, but I'm assuming that we're at about 1:15 right now. So can we come back at about 5 minutes till, please? And we'll start with our panel at 5 minutes till. Thank you.